All right, good afternoon or good morning, everybody, depending where you are in the world today. I am Marissa, and I'm going to be moderating today's Adults with Developmental Disabilities Series Part 1 webinar today, brought to you by Mr. Kevin Fitzgerald. So thank you all for coming today. Today's presentation is only an hour and a half, and you will have the chance to earn 1 CEU. If you did not already purchase the option to earn CEUs today, don't worry. It's going to take me a little bit longer to analyze the CEU data that we get. So you'll have over the weekend even to purchase that ability to earn today. If you have, okay, so I was told not to send the presentation prior to the webinar today. So if you wanted to download a copy of the slides, they're right there in the handouts section of the control panel. You can just download and print there, or you can send me an email, and after the presentation, I can attach it and send it to you as well. Let's just get through my little, let's see what I gotta say here. Okay, we will not be taking a break today because it is a short session, and we will be taking your questions kind of as they come in. So please feel free, use that section, the questions section of the control panel, and we will get to your questions probably within a few minutes of you submitting them. You will have to answer some poll questions. There's only a couple because it's a short presentation to earn that CEU that you want if you wanted to purchase that ability. So just make sure that when those polls pop up, you answer them and you stay the entire time, and you will qualify for that. I think that's all I have to say for now. So I'm going to turn my camera off and turn it over to Kevin.
Thank you, Marissa, as always, and thank you, everybody, this afternoon for joining me. As always, I'm humbled and I'm honored that people think that I have something that's important to hear. Obviously, I think I do, but my opinion really doesn't matter. But today we're going to talk about psychotropic medications, and we're going to cover a lot of material in a relatively short period of time. So we're going to move quickly. I just want to start out by reading this disclaimer, and I'll read it. You can see it for yourself. Please be advised that I am not attempting to represent myself as a medical doctor or as someone who can prescribe medication. The information and observations contained within this webinar are based upon my 35 years of experience in working with dually diagnosed, and dually diagnosed in this context means mentally ill / developmentally disabled adults. I have had the extreme pleasure and benefit of working collaboratively with several outstanding psychiatrists, and many of my opinions and beliefs are based upon what I have learned from some of these brilliant practitioners. Studying and staying current with the field of psychopharmacology has been and continues to be a lifelong passion of mine. So having said that, let's begin. Let's talk about some general diagnostic issues that impact our population. And again, everything I'm talking about today and everything that I'm targeting in the series, the 6-part series, is specific to adults with intellectual or developmental disabilities, which is typically considered to be above the age of 21 or 22, depending upon what state you're in. As a general rule, it can be exceptionally difficult, this is an understatement, to diagnose nonverbal lower functioning individuals who cannot directly contribute to the evaluation and assessment process. Many psychiatrists are not adequately trained and or comfortable serving this population. Now, please don't take that as a knock on psychiatrists in general and that practice out in the community. Those of us that have worked with our folks for many, many years and have had that privilege and the pleasure know that just as the nature of their disabilities and their limited, oftentimes expressive speech or even ability to expressively communicate clearly compromises a psychiatrist's ability to be able to diagnose an individual when a lot of psychiatry is based on individual self-reports, feeling states, their thought processes. That's usually how psychiatrists start to evolve a diagnostic impression of what they're dealing with. So if you take that out of the equation, you can immediately see how challenging this can be, and it is for all of us, for some of us more than others. It has been well established that individuals with developmental disabilities are more susceptible to developing some form of mental illness as compared to adults in the general population. So most of the research shows about a 50% probability that an adult with intellectual disabilities will develop some kind of legitimate DSM-5 psychiatric illness over the course of their lifespan. I'm not sure what, I think in the general population, that percentage might be closer to 30%. I'm not exactly sure, but I even think the 50% is a bit of an underestimation. I think people with intellectual disabilities are just more predisposed for many, many reasons to develop mental health issues. Personally, I believe one of the most overlooked diagnoses in our population is depression. This can include forms that I refer to as agitated depression. Now, let me expand on that a little bit. In my experience, which has covered 3.5 decades, and probably involved working with literally thousands of people, I can't think of a lot of individuals I've worked with or supported that were ascribed a diagnosis of clinical depression. I'm not saying it hasn't happened, but it hasn't happened anywhere near the frequency that I believe it probably could have or should have, because I think people with intellectual disabilities are predisposed for lots of reasons to develop depression. But it's very rare that I see that happen and then see a person be prescribed on just a single antidepressant medication. Just an observation of mine. Also, there is a form of depression that I refer to as agitated depression. So when we think of depression in its classic sense, right? People have no interest. They don't have a lot of ambition to do things. Maybe they sleep excessively. Maybe they cry a lot. Maybe they express feelings of disappointment or whatever, unhappiness. But I've worked with a number of people that their depression can be manifested possibly as physical aggression. I mean, they're depressed, but they're mad. So they're not depressed in the classic sense. They're just sitting back passively and being depressed. The depression comes out in a more overt, demonstrative kind of way. I've experienced this quite a bit in my career, and I think it's a legitimate observation. So as I'm saying this, I'm always curious to know, as you're listening to me, as you go back in your own caseloads and your experiences, I'll bet that some of you are thinking, oh yeah, I saw someone that kind of met that definition or presented that way. So I'll be curious to hear your feedback on that. We need to be very careful when recording and maintaining data which impacts prescribing of psychotropic medications. Are we simply treating behaviors, or are we treating symptoms of a suspected mental illness that may have a behavioral expression or manifestation? This is a very important distinction. So let me elaborate just a little bit on that, because this is a really significant and profound point that gets lost all the time. I've been involved in consultations, psychiatric evaluations of folks with disabilities, where the only thing that's discussed during that consult is the person's problematic, challenging, aberrant behaviors. Well, doc, they engage in self-injurious behavior, they do this, and they have physical aggression, and then they have property destruction. And so all we're really talking about diagnostically are the behaviors that a person exhibits that we wish they didn't exhibit. We're getting away from the whole idea of ascribing a legitimate DSM-5 diagnosis. The reason why that's relevant is that if that's all we talk about, and those are the only behaviors that we're monitoring, then we have to be very careful that we're not just simply prescribing psychiatric medications for the primary or entire purpose of suppressing aberrant behaviors, because that's not what we're supposed to be doing. We're not supposed to be sedating people to be cooperative and compliant. That can be a part of it. I'm not saying it isn't. But if that's solely what we're doing, then I think we've kind of missed the mark on what it is we're supposed to be doing. And I would argue if that's what we're doing in 2021, we were doing that back in the 1980s, and I was involved in the field back in the 80s. So I like to think that we've come a lot longer than that. We're more sophisticated than that. Diagnostic issues, interesting to me that these two things have the same acronym, BPD. BPD, which stands for bipolar disorder. Again, these are my observations, opinion based on dealing with hundreds, probably thousands of folks, lots of different environments, lots of different settings. This is what I firmly believe. Bipolar disorder is likely overdiagnosed. This diagnosis justifies the administration of many different classifications of medications. It seems to be a very popular diagnosis, and in fact, it has been for the last 10 years. And we'll talk a little bit about why that might be. Interestingly, the other BPD, the one we don't like to talk about so much, borderline personality disorder, in my opinion, is likely underdiagnosed. One of the reasons is that individuals with borderline personality disorder oftentimes do not respond to psychotropic medication treatment or intervention. So, you know, those of us that have been doing this for a while know that it's very, very difficult from a psychiatric medication perspective to treat effectively a person with a borderline personality disorder. That is not to say that we don't try. And sometimes we try very vigorously. It might be an anti-anxiety med, it might be a mood stabilizer, it's oftentimes an antipsychotic. We throw lots of things at people with borderline personality disorder, hoping something might work. But many, many times, because of the nature of this particular disorder, people may not respond as favorably to psychotropic meds as some of the other conditions may. I just want to, this is why, by the way, I didn't have Marissa send out the PowerPoint last night, because I had some ideas last minute about making some additions to this presentation, which I did last night, literally at about 11 o'clock. And I wanted to add a couple of characteristics of what I see of presentations of borderline personality disorder. These, again, my observations based on 35 years. There's oftentimes, these are not, you're not going to find this anywhere, I don't think, where it's clear cut. This is just a smattering of things that usually are associated with that particular diagnosis. History of family abuse, dysfunction, or pathology. Very, very, very common that people with a borderline personality disorder have had some difficulty in the family unit, physical abuse, neglect, all kinds of things. B, individuals with the borderline can oftentimes be extremely polite, and I boldface that for emphasis for intention. I mean, very, very polite, very friendly, very respectful, unbelievably so. But then they can also quickly revert to being rude, hurtful, and demeaning. They can go through these major extremes of presentation, which is really quite remarkable. And just as an aside, you should never really share personal information with a person that you suspect has a personality disorder, because you will pay a very dear price for that. Trust me. That information will come out when you least expect it, and it probably won't be pleasant. They might wish bad things on you or your family or your children. It can be really ugly. So as a general rule, and also from a boundary perspective, I think it's wise for us or staff not to share personal information with people with suspected borderline. Oftentimes you see sexual confusion or displaced emotions or feelings, frequently towards staff. Not unusual for people with borderline to think that they're falling in love with a staff person, male, female, whatever, and displace their emotions onto staff. This happens actually quite a bit. They also tend to have an inability to initiate or maintain healthy, intimate relationships. There's really not any reciprocity in those relationships. They tend to be kind of controlling. What's in it for me? How can I benefit from being in this relationship with you? It's very egocentric and self-centered. It's not really reciprocal, like we would think of your typical healthy relationship. Very, very common, and I know you've all seen this likely. is the superficial cutting or other forms of self-injury. That happens quite a bit with people with borderline personality disorder. Extreme egocentricity or need to be the center of attention. Again, another fairly common characteristic. F, this is a very common characteristic and a very difficult habit to break. Frequent need or desire to go to the emergency room. They will do things behaviorally, demonstratively, that force us to sometimes get outside parties involved. And yes, I'm talking 911, police, fire department, what have you. Then they come and they evaluate a person that appears to be very much dysregulated, out of control, it's not safe. So they make a determination to take the person to the emergency room, which oftentimes is exactly where they want to go. They feel safe there. They feel that they're understood there. They feel that that's like their safe haven. This can be a very difficult habit to break if you get on a roll and this becomes a pattern of response or reaction to what the person with borderline is doing. You want to avoid this, trust me, as much as you possibly can. And lastly, there are more, but these are just some of the core characteristics that I've come across. This incredible sense of entitlement, belief that they should be able to go straight to the top with their issues, complaints, and concerns. Not unusual for a person with a complaint with a personality disorder. Doesn't want to talk to the staff, doesn't want to talk to the residential manager, doesn't want to talk to the program director. They want to talk to the executive director, and they want to talk to that person now. And when they go to pick up the phone, they expect the executive director to be there to hear their complaint. So it's like they want to skip the chain of command because they feel like they should have access right to the main decision makers. So again, I hope that's helpful. Some of you may have seen some of these characteristics. Some of you might be nodding your head affirmatively and saying, yeah, I've seen all of this. And some of you may be seeing this for the first time. But I just wanted to share that overview with you because the fact of the matter is people are reluctant to ascribe a diagnosis of borderline personality disorder because you can't really treat it effectively from a psychopharmacologic perspective. From a behavioral perspective, it's exceptionally difficult. Very, very difficult. Usually behavior support plans have to focus on limitations, structure, rigid boundaries. Those things are difficult to implement. Very challenging, very difficult to implement. When you do it and you do it well, people can actually improve quite dramatically, but they present such an incredibly difficult challenge that a lot of people just get burned out or they just can't programmatically provide the structure that's necessary for people with a borderline disorder to improve or sustain that improvement over time. Bipolar disorder is oftentimes described when practitioners see significant fluctuations in behavioral data. I see this a lot. Exacerbations and/or fluctuations of behavioral presentation do not necessarily equate to a diagnosis of bipolar disorder. So what happens a lot in my experience, you go into psychiatric assessment, evaluation, consultation, whatever, and the staff come in with a laundry list of data of all the things this person has done over the past several weeks or few months. And they start to talk about this person is starting to escalate. We haven't seen this before. The intensity is much higher than it used to be. The frequency is off the charts. And oftentimes psychiatrists will immediately embrace that and convert that into what they believe to be some kind of a manic presentation, which it's not. Oftentimes it's not. But that's their interpretation of the data because you see a spike, you see a rapid escalation, and that acutes to what they believe to be a manic episode or presentation. So I oftentimes try to caution them to not jump to that conclusion. But sometimes I can intervene, and sometimes they just disregard what I have to say and go with it anyway. But be aware of that a spike in behavior doesn't necessarily equate to a manic episode or a bipolar disorder, because oftentimes psychiatrists will take you there. The other point about bipolar disorder, again, because it's so widely diagnosed, is that my experience, again, has been adults diagnosed with bipolar disorder rarely exhibit features of the depressive phase of the disorder. So bipolar disorder is mania and depression, right? And fluctuations in between, and extremes. So when we go in there and we say they're doing this, we've never seen this, the frequency is high, the intensity is higher, and we say, oh, that's mania. Well, then my question is, okay, where's the depressive phase? And usually it doesn't exist. There's no evidence that that other extreme of the mood state is ever being manifested by the person. So if bipolar disorder involves this fluctuation between extremes and there's no extreme here, then how is that meet the criteria for bipolar disorder? I'm not sure that it does. I'm not sure that it does. Finally, diagnostically, be wary of diagnoses that contain NOS. NOS stands for not otherwise specified. NOS. So if someone attempts to, like what I see a lot of, psychotic disorder, NOS, depressive disorder, NOS, anxiety disorder, NOS. So whenever I see NOS, it basically means, this is my interpretation of what it means. If there's any psychiatrist listening, please don't take offense. It means that they don't meet the criteria, but I think they might have it anyway. So they don't meet the criteria for this diagnosis, but I'm going to put NOS on the end because it doesn't fit nicely compartmentalized into that diagnostic picture. It doesn't meet the established criteria, but I think they might have it. So I'm going to put an NOS after it, not otherwise specified, or another way of saying that it doesn't meet the rigid criteria. I'm always a little bit suspicious of those diagnoses because it's an immediate red flag for me that the person doesn't truly meet the established criteria for that diagnosis. Yet we're trying to kind of pigeonhole them into that anyway. There might be some validity to it. Oftentimes, I'm not sure that there is. Why don't we see if there's any questions before we do poll question number one, Marissa?
Sure. Okay, so it looks like, let me see. We don't actually have any current questions, just one about the downloading the presentation. As I said, you can download it under the handouts section of the control panel, or you can send me an email and I will send it to you after the presentation. I typically I try not to check my email so I could be very attentive for the webinars. So please just send it over afterwards. Marianne, thank you so much for all of your feedback over here. I see you're very participating today. All right. You're present too. Okay, awesome. So that's all we have for questions. Did you want me to launch a poll?
I'm scared that there's no questions. I've never had that before. I don't know what that means.
Oh, actually, let's see.
Yeah, someone ask a question, please, just to make me more comfortable. Anything.
Heather's wondering if you could review your reference to the limitations in programming for BPD.
And is that a BPD for bipolar disorder or borderline personality disorder? Probably borderline personality disorder, right? I just want to clarify.
Probably, yeah, she said yes.
Yeah, so behavioral programming and interventions for people with borderline personality disorder usually involve lots of structure, lots of limitations, sometimes restrictive components. And again, I know that's a dirty word and I don't like that word, but for this particular disorder, some level of restrictions is oftentimes necessary. Levels of supervision are usually higher than what they need to be for people with other conditions. It's not easy to a lot of the failure of a lot of agencies, a lot of people that I see getting kicked out of agencies over the years, just because clinically, behaviorally, they couldn't be effectively managed for people with borderline personality disorder. High burnout rate among the staff. Staff tend to take things personally. What did I tell you? Don't share personal information. If you start talking to one of the individuals that you support and you tell them about what you and your family did last weekend and what kids you have at home, what their names are, what their ages are, what you do for fun, I'm telling you, they're taking that all in. And at some point, probably in the not too distant future, that information is going to come back to you, and it's not going to be in a pleasant way. And that's when staff, they tend to, here's an expression I've used for years with people with borderline personality disorder. And I've worked with dozens, if not hundreds, because I just tend to get a bunch of them. Whenever I meet or interact with a person with a bipolar disorder, I say, I don't say it to them, but this is how I think about it. I have on a titanium shield. You can't penetrate. You can't penetrate me. You can't get through to me. You can't say something about me personally that's going to offend me. I'm impenetrable. And it's a difficult thing to be able to do, but I've done this long enough that I'm actually able to do it. And when you're able to make sure that you have that boundary in place and nothing can get through that, you can look at things in a little bit more of an unbiased, objective perspective, because you're not letting the person get through to your core and your emotions, and you're being upset, or they offend you, or they're saying really nasty things about your husband or your children. So again, those are, I don't want to beat a dead horse here, but those are some of the challenges in dealing with people with borderline personality disorder, and why they tend to be the most challenging element of the population of people that we support and work with. So why don't we do poll question 1?
Okay. So everybody, this is what the poll questions look like. I know many of you have already come to our webinars before, but just in case you haven't. So some of the reasons why diagnosing adults with DD/ID can be difficult include the following, and you can select all that apply. Oftentimes individuals are nonverbal. Data is either unavailable or inaccurate. We tend to overdiagnose certain conditions, or we track behaviors versus psychiatric symptoms. Now, if you're having any trouble at all with using the poll interface itself through the GoToWebinar platform, do not worry at all. Please feel free to write your answer down in a Word document or the body of an email and send it to me after the presentation, and that will perfectly suffice for your participation grade. Well, participation credit, I should say. Alrighty, so I see that the number is slowly trickling up. Just remember that if you do want those that CEU for this presentation, you do need to participate in these poll questions. If you don't answer the poll questions today, then you will not qualify for the CEU. So just keep that in mind. All right, I'm going to shut this out in 5, 4, 3. There's last few voters. 2. Okay. And 1. I hope I left enough time. It looks like 83% said A, 77% said B, 89% said C, and 83% said D.
Yep. So the answers, of course, is A, B, C, and D. All of them are relevant based on the information we're presenting today. Thank you for responding, folks. Any other questions before I proceed with medication-related issues?
There are quite a few questions. People
I
ended up.
knew they were coming. I knew it.
Yeah.
Let's
So
do a couple.
Sure. Okay. So when describing programming in the BSP, can you indicate what you program for?
I'm not sure I'm not sure I understand the question.
Hey, Kelly, can you submit maybe a little bit more information and we'll come back to your question at another time? Even if you wanted to restate your question when you resubmit, that might be the easiest way for us to come back to it later. Okay, so let's see. When it comes to reading psychological evaluations, what are some other red flags to look out for?
Again, I would need to know what kind of a psychological evaluation. Let me go back to that previous question because I think I know what she's getting at. So
Sure.
when you're looking at structuring a behavior support plan for people with borderline personality disorder, the things I tend to focus on are boundaries. A target behavior to increase is appropriate interpersonal boundaries, because that tends to be an issue. Maybe treating staff and peers in an appropriate and respectful manner, because they can be very verbally abusive and demeaning. Those are the kinds of target behaviors Again, it would need to be specific to the person, but generally speaking, those are a couple of examples of things you would probably appropriate term taking. That can be a real problem for people with borderline. They always want to be the first one at the first one in line and the last one to leave. So it can be very challenging to get people to understand, if they live with 2 or 3 peers, that they all have the same rights and privileges as they do. That's not oftentimes doesn't come with the territory. So you got to kind of teach that skill, because it's not something they normally embrace. The psychological evaluation question, from my perspective, I would look at some of the characteristics that I described, A through F. I think I covered some of the most common characteristics, and see if any of those are reflected in the I mean, I would need to know what kind of assessment the person is referring to, how it was structured, because there's so many different variations of these things. But I think if you focus on some of the core characteristics I gave you, that might help you be able to interpret some of what you're reading and some of the more standard psychological assessments. I'll take one more question before I move on, if you have one, Marissa.
Sure. Okay, so hey Kevin, I currently started working with a client who has ID and borderline. As part of the diagnosis, the client is calling all of his care team. Would you recommend one point of contact for these clients?
Absolutely. So here's what we know, and I don't want to spend a lot of time on it, but one of the most efficacious forms of therapy, and I know we're not talking about therapy today, but is DBT, or dialectical behavior therapy, which tends to have a fairly good track record with people with borderline personality disorders. And part of that curriculum, and I'm not claiming to be an expert in it, I know a little bit about it, not a lot. Part of that curriculum involves having there be a point person, that individual, when they're feeling dysregulated, out of control, emotionally fragile, that they can reach out to, speak to, and work the issues through. So yes, I think it's a very good idea, generally speaking, to have a point person rather than have the person feel like anybody on their team, which could encompass as many as 10 or 12 different people, is fair game. I think that helps them structure and compartmentalize what an appropriate response should be when they're feeling particularly dysregulated. I think that's a good question and a good idea to go about it from that perspective. So let's talk about medication issues. We talked about the diagnostic stuff. Generally speaking, monotherapy is almost always most desirable, though seems to be quite rare. Monotherapy obviously means being on a single psychotropic medication. Highly unusual, unfortunately, but it is. At least that's been my experience. If someone out there knows some state or some country where people with intellectual disabilities with a psychiatric disorder are on a single medication, and that's the rule rather than the exception, I would love to hear about it, because I'm not sure it exists. Be extremely careful when prescribing medications that need to be monitored via blood levels. Questions to be asked include the following. So these are the questions I ask. Does the person receive adequate hydration? I talked about this in some other webinars. Chronic dehydration in our population is the rule. It happens all the time. People do not take in enough liquids, enough fluids, as a general rule, when they live in group home living situations, supported living situations with staffing, unless they can independently access fluids on their own, which doesn't happen all the time. Usually staff have some role in the acquisition of fluids. People tend to be chronically underhydrated. This can obviously affect blood levels, obviously. So be aware of this. This is a real problem. How often will blood levels be done? Well, that's an interesting question. I demand, well, I can't demand, but I try to demand that people get blood work done every 3 months. And one of the main reasons for that is 2 of the main indicators of people becoming potentially toxic on medications, which you would monitor via blood levels, is impaired speech and gait or ambulation disturbance. So if you give me a person who doesn't speak, I That doesn't help me. That's not a good indicator because they don't talk or they don't expressively communicate. So I can't use that as a as an indicator. And if I'm dealing with a person that is in a wheelchair or uses a walker or normally has difficulty ambulating at baseline, then I can't use the gait issue as a possible indicator of toxicity as well. So for all those reasons, and have I had people become toxic on medications over my career? Yes. If I had people become so toxic on medications over my career that they passed away as a direct consequence of that? Yes. So in my world, in my opinion, 3 months, no longer. A lot of doctors will try to go 6. I don't like it. And I will raise these points that they're not going to be able to see signs of potential toxicity like they do in the non-disabled population. So better to err on the side of caution. That's my belief. And I feel strongly about that. Does the person have an aversion to blood draws or needles? Well, this is certainly relevant, isn't it? If you're putting a person on Clozaril, as an example, and the person has to go for weekly blood work, and then after 6 months goes to biweekly and then eventually monthly. But for many, many weeks, they're going to be going to have blood levels done. You're looking for white blood cell counts here because that's one of the side effects of Clozaril. It's a depletion of white blood cells, which can potentially be fatal. So it's a very serious side effect. If that person doesn't like needles, like I got vaccinated, folks, but I wasn't crazy about it. I have a bit of an aversion to needles. I'm not sure I'd want to go every week and have blood work. So if you have an individual that's got a particular problem with that, you should probably be aware of that if the medication that's about to be prescribed is going to require frequent blood draws. Right? Makes sense? Blood levels required for mood stabilization purposes, such as Depakote and Tegretol, can be significantly higher than therapeutic levels recognized for seizure control. Avoid WNL. WNL is an acronym that stands for within normal limits. Or I once asked a physician who was a friend of mine what he thought WNL stood for, and he said, "We never looked." That's a joke between he and I, but I thought it was funny. So within normal limits. The reason why we need to get the actual number. Let's take Depakote as an example. The therapeutic level of Depakote is between 50 and 100. That's for seizure control. Seizure control. I've never seen an article that pinpoints precisely what the therapeutic level of Depakote is when it's being used as a mood stabilizer. But I do know that it can oftentimes be well above 100. So a person who's getting Depakote as a mood stabilizer will oftentimes need to be maintained at a level of 110, 120, maybe even high as 130. And as long as they're not showing any signs of toxicity, that's okay. But that would be a much higher blood level than one would need to obtain for seizure control. The same is true with Tegretol. So it's pretty well known at this point that when we're using these anticonvulsants that have now been used as mood stabilizing agents for many, many years, that blood levels that are required for that purpose are much higher than their original intended purpose, which is control seizures. Be extremely careful if when prescribing lithium, as individuals are quite prone to toxicity due to inadequate hydration. Lithium is still the #1 drug of choice, in my opinion, if a person has a true, verifiable, legitimate bipolar disorder. But it's a very dangerous medication because it can fluctuate dramatically depending upon how much fluids the person is taking in. And if they're not taking in enough fluids, which I said is a chronic problem in the field, their lithium levels can skyrocket. They can become toxic and very, very sick and even die. I have had at least one individual die of acute lithium toxicity many years ago, but I've never forgotten about it. Try to identify the threshold dose where you can achieve optimal clinical results at the lowest possible dose of medication. So the general rule in the field is use the least amount of medications at the lowest possible dosages. That's pretty much the mantra. That's the standard. So, you always want to be trying to minimize the amount of medication a person needs to the point that they can still maintain themselves and you're still getting good symptom control over whatever mental illness has been identified that the individual might have. The standard is true for all of us. We don't want to be on any more medications than we need to be. And if we are on medications that we must be for our health and safety or even our own mental health, then we'd like to be on the least amount of medications as possible, because all of these medications have significant side effects. I mean, virtually every medication has side effects. When titrating medication, so when you're trying to lower medications, titrating can mean going up or going down, but in this case, I'm referring to going down. When titrating medications, with rare exception, make one change at a time to avoid conflicts and confounding variables. So if the person's going through a day program change, a change of residence, their mom and dad just passed away in a tragic car accident, they're dealing with the anxiety that we're all feeling through the prolonged COVID pandemic, and someone makes a medication change, and all these other things are going on at the same time, and we immediately want to say, oh, they're getting worse or they're getting better. That's because of that med change. Well, that's a bit disingenuous, right? Because we can't necessarily pinpoint that that's the causative factor. So just be aware. We live in a world of confounding variables with our folks. It's just the nature of the work we do. There's nothing experimental. There's nothing controlled about any of this. Here's something that I've just noticed over many years. When a medication has been discontinued, give the person 6 to 8 weeks to get acclimated before making a decision or determination that the person needs to be placed back on the medication. Folks, remember, a lot of these individuals have been maintained on these medications for extended periods of time. So they're very sensitive when we try to do med reductions, if not an attempt to discontinue a medication. So what I see oftentimes, very often, particularly with antipsychotic medications, to be quite honest with you, someone is doing very well from a behavioral perspective, mental health perspective, been on an antipsychotic for a decade, and someone decides, as I think they rightfully should, they want to be able to demonstrate whether or not the person still needs that medication at that amount, or if they need it at all. So they start to do a gradual titration and maybe a discontinuation. And then a week or two after the med's been stopped, the person starts to rapidly decompensate. And everybody goes into a full-blown panic. Oh my God, get them back on the med. This is terrible. We can't deal with this. This is unacceptable. They're doing very poorly. Well, my experience, for what it's worth, has been when I don't have that knee-jerk reaction and I kind of wait it out, provide a few more supports to the person to get them through that difficult period of having their body adjust to not being on that med anymore. My experience is oftentimes a month and a half to 2 months, 6 to 8 weeks. They work it through and they actually get back to baseline of how they presented when they were on the med. They work it through and they prove to me at that point and others that at least at that point in their life, they don't need to be on that particular medication, which is a good thing. So again, keep in mind that it sometimes takes, people don't have the patience usually to get through that difficult period, either the individual, him or herself, or the staff working with them. Another issue is when titrating medications, sometimes they need to be made very slowly. You rarely see what I'm proposing here, 5% increments, for the person to successfully tolerate the reduction. There was a very famous psychiatrist by the name of Dr. Robert Savner. I call him the late great Robert Savner, who did a lot of work with people with intellectual disabilities. He was brilliant. He died much earlier than he should have, I think, due to pancreatic cancer. He was truly a pioneer and a very brilliant man. I got to work with him on a couple of cases, and it's always profoundly affected me, his knowledge and his brilliance. And he was the one that made me aware that he actually had a name for this. He called it supersensitivity psychosis. And what that meant is if you try to decrease a med that a person's been on too quickly could be 25%. That's not unusual. 25%, even 50%. If you do that in one fell swoop, the person probably, in many cases, will not be able to handle it. So he came up with the idea of doing these very small incremental reductions that take much longer to get the person off. But usually when they're done properly, the end result is far better than making these dramatic reductions that are usually at amounts that in many cases the person simply can't tolerate. So that's my ode to the late great Dr. Robert Souter. Psychotropic medication should not be viewed as a quick fix unless there is evidence that a person would not or could not benefit from proper behavioral and environmental interventions, which I think is rare. I think the vast majority of people can benefit from some kind of a structured plan, making environmental modifications, being aware of antecedents, precursors, setting events, all of that stuff. If you're a good clinician and you're aware of what all of these factors are and how to recognize them and make adjustments and help the person develop coping mechanism, you can do a tremendous amount of good clinical work, behavioral work, without necessarily relying on psychotropic medications. But I still come across many instances where people think medication is the answer. Behavior support plans take work. To implement them takes work. To take data on them takes work. But many people have this very naive perspective that, oh, let's take them to the psychiatrist and get them on meds. Well, be careful what you wish for, because that may not solve the problem. In fact, it may make it worse. So as I'm saying here, medication should not typically be the first thing that is considered by the person's support team, although sometimes it is. Many psychotropic medications can have potentially serious side effects. I can't even. I could give you a dictionary of all. I mean, it'd be a very copious. But some of the major side effects, there's hundreds, thousands of side effects. Some of the most serious ones, and interfering and obvious ones, are weight gain, agranulocytosis, development of type 2 diabetes. Almost all the atypical psychotic medications on the market these days, particularly Zyprexa, notorious. And if you put a person on Zyprexa, there's a distinct probability they're going to develop type 2 diabetes. So you better be monitoring it real close. Lethargy, somnolence. Most of the medications, particularly antipsychotics, can cause drowsiness, tiredness, lack of energy. And if you're not aware that that's a side effect of the medication, you may interpret that in more of an overt behavioral way that's not necessarily accurate or valid. So all of these side effects should be monitored very carefully, constantly utilizing a risk-benefit type of analysis. How much is the person being compromised versus how much benefit are they getting from the medication? I'm constantly weighing those factors for everybody that I'm privileged to work with. It would be nice to see more collaboration between the various medical disciplines when an individual is being treated psychiatrically. We could say this probably for our own care as well, but this is really kind of egregious when it comes to people with intellectual or developmental disabilities. The best work comes through a collaborative effort. You know, when the psychiatrist is talking to the PCP, who's consulting with the neurologist, who's working with the endocrinologist, when you have a real good team approach and all the disciplines are involved and aware of what their piece in the plan is, you tend to get the best quality psychiatric care you can get. But it's very difficult sometimes to get these disciplines to collaborate for lots of reasons. Let me take any quick questions before we get poll question number 2.
Okay, well, we do have quite a bit of questions from earlier as well, so I'll try
Just
to.
remind people that we're going to stay on for an entire half hour after 2 o'clock, just for this reason, for all the questions.
Right, everybody. So what we'll do is right now we'll try to take like the quick ones, and then towards the presentation, the last like half hour of the presentation, we will go into more depth for your questions. So don't feel like I'm skipping around if you feel like I haven't said it yet. Okay, so I'm going to try to do from like the last few minutes. How about, have you been following the research on catania in autism? It appears many with autism actually are displaying catania, or catania. And then now we're doing Ativan challenges with some amazing results when they have been on toxic cocktails of psychotropic medication for years. 25 years of experience here as a behaviorist.
Fascinating. I'm not aware of that.
Well, 35
Because
years. Sorry, 35 years.
oh, that person matches me. I better listen. I'm just kidding. I'd love to know more. I'm not familiar with that. I don't pretend to be aware of everything that's going on. And the vast majority of people that I work with actually don't have a primary diagnosis of autism. So I'm not surprised that I'm not as up on that as I probably should be. So no, the answer is I'm not aware of that, but I love. I will caution people about this. I'm always a bit suspicious. This is just the cynical part of me, which is huge. When I hear these borderline miraculous results about anything, I'm cautiously optimistic, but that sounds exceptionally encouraging, and I hope it proves to be uh, as efficacious as that person seems to be describing. But no, I'm not personally familiar with that.
Okay. So have you seen patients engaging in overhydration due to certain medications or diagnosis?
Yeah, that's an interesting question. It's a good question. You have to be careful. Some of the side effects of medication are excessive thirst. So let's take a person that might have a history of polydipsia or water intoxication. You better be careful because they may have their mouth under that sink. And that can be a problem. So if that becomes a problem for people that I work with, usually I've had some success with chewing gum if they won't swallow it, ice chips, biotin, which is the spray that is commercially available to kind of, just provide some hydration of the mouth, the oral cavity. Those are all good options to that side effect if that's why the person is experiencing excessive thirst. So in the interest of time, Marissa, since I've got 7 minutes and much to cover, we better do poll question 2.
Sure. Okay, everybody. So as a general rule, which is the most correct or accurate statement? And please select one. Quality psychiatric services are widely available. There are a few side effects that need to be monitored. True collaboration amongst medical professionals is rare. Adequate hydration is rarely a problem or issue. And monotherapy or single medication is quite common. Okay, everybody, so please get your votes in. And as I said, if you're having any trouble with the interface, you can put it in a Word document or the body of an email and send it to me afterwards. And it will perfectly suffice for your participation. But do make sure you answer these polls if you have an interest in purchasing CEs or you already did. It's very important that you do, otherwise you will not qualify for that CEU, even if you're here. So you will not qualify if you don't answer the poll questions. Okay, so this number is slowly trickling in. We do have a lot to cover in the last few minutes of here, so I am going to shut this out in 3, 2, 1. Okay, those last people are going to miss out. And it looks like 10% said A, 3% said B, 81% said C, 3% said D, and 3% said E.
All right, they got a home run on that one. Thank God. Yep, she is the main problem child there. So let's move on. We're almost at the end. Sedates. This is an interesting topic, issue, concern. Medication is oftentimes given to individuals prior to any type of medical appointment and/or invasive medical procedure. Dental procedures are a big problem for lots of our folks. I wasn't thrilled with the dentist myself. Still am not. Gynecologic for our female folks. Not something that everyone just goes to with an open mind and pleasantly and happily. So that's when we come up with the idea of let's give them a sedative prior to the appointment, usually Ativan, sometimes Xanax, sometimes Valium, or a combination of all of the above. And that will calm them down to the point that they'll be able to get through the appointment without any major problems. Well, we're going to talk about that. Be aware that many individuals have fear or apprehension that is based on prior real-life experiences. The reason why that's relevant is because the definition of a phobia typically involves an irrational fear. So my point here is some of the reasons why pre-sedates don't oftentimes work as well as we'd like them to is because their fear or their distress or their anxiety, their borderline PTSD about going through a medical procedure isn't based on an irrational fear. They've had something really bad happen to them at some point in their life, particularly folks that are older that have lived in institutional settings. Trust me, most of those people have gone through medical procedures and interventions that you and I wouldn't want to go through. They probably weren't properly sedated. I have individuals that were tied down to papoose board so the net just could get in their mouth and do what they needed to do while their arms were tied down and they couldn't assault anybody. Well, that's not exactly going to make them more cooperative with the next appointment, is it? So I want you to take into account that some of these people have real life experiences that they recall, that they've never forgotten about, that causes them to become very uncooperative with some of these procedures. Pre-sedates prior to medical appointments and procedures oftentimes have a paradoxical effect. This has been my experience. It actually makes the individual worse, not better. So if you're giving a person a pre-sedate, you should be monitoring that very carefully to see if it's actually helping facilitate the appointment to the procedure. Because I have a number of people that I work with, they get the sedative, so they know where they're going and they know they're not going to like it. So now they have to overcome the fact that I'm trying to sedate them and the original fear or apprehension about the procedure itself. So now I've got a double whammy. So now they're going to become even more combative, more uncooperative, more non-compliant because they know that I'm trying to give them something that's going to get them through the appointment. It's very interesting when that is an individual's response, and that's not uncommon. I'll be happy to hear what other people's experiences have been if there's any questions or answers in that regard in the last half hour. Let's get into quickly and lastly data-related issues. What are the exact symptoms that staff are expected to track monitor? If we're trying to determine the efficacy of a psychotropic medication, how are we judging the efficacy of that medication? Based on what? And usually good, solid, reliable, verifiable, accurate data in this area tends to be grossly lacking. It's a problem that pervades the field. If we are only interested in reduction or elimination of aberrant behaviors, aren't we prescribing medications, frequently including antipsychotics, primarily, if not solely, for the purpose of behavioral suppression? This is the question I raised at the beginning of the webinar today. I want to see if a person's exhibiting anxiety, I want to see anxiety described as to how that person manifests anxiety, excessive pacing, something that we can track and monitor that's observable, that's somewhat empirical, that staff can hopefully take data on so that we can determine the effectiveness of the medication that's being prescribed to treat allegedly anxiety. When analyzing data, can we reasonably account for some of the fluctuations of the data based on reasonable identification of external variables that might be solely responsible, if not at least contributory, rather than attribute everything to the meds? So it continues to fascinate me and amaze me and somewhat disturb me that people can go for a psych appointment after 3 months, where a med adjustment might have been made 3 months previous, and then staff go in there. And I'm not trying to talk about staff in a demeaning way, because nobody respects direct care staff more than me if you've attended my other webinars. Nobody. These people are unbelievable. But if they go in there and they're not really prepared and they don't really have the data and the doc says, well, okay, I decreased his Celexa last month by 10 milligrams. How are they doing? And the staff say, oh, it's bad. It's been a real rough 3 months. And there's no other discussion about anything, then isn't it really disingenuous and almost unethical to make a determination that the sole reason as to why that person might have regressed or decompensated somewhat over the past 3 months is that reduction of a medication that occurred 3 months previous? What is going on in that person's life over 3 months that might be partially, if not wholly, responsible for their increased difficulties? Let's put that out there on the table, because that's what we should be doing as clinicians that have good observational skills. We should be sharing that information. Remember, it is not uncommon for many individuals to get worse, not better, on psychotropic medications. So not everybody just by default gets better because they're put on psych meds. It just doesn't happen. Many people that I've worked with over the years get dramatically better when they're taken off of them. That's happened to me many, many times. They feel better. They're not experiencing the side effects. They're more clear-headed, and they'll tell me this. They'll tell me this. I'm feeling so much better, Kevin, and I'm glad. I'm glad for you. You know, that's phenomenal. That's awesome. Also look out for possible paradoxical effects. You know, not everybody, the way individuals respond to psychotropic meds is incredibly variable and idiosyncratic and very unique. Not everybody responds the same. None of us do. So just be aware how an individual might respond to certain medications, because not only might it make them worse, if you're putting them on something to treat anxiety, they could become more anxious. Or if you're treating someone with an antidepressant, they could actually become more depressed. So just be aware that this is something that can and does occur, probably more frequently than you might think. Having said that, let's get to the simple true or false poll question 3.
Okay, everybody. So be careful when using pre-sedating medications for medical procedures, as they can oftentimes have a paradoxical effect. True or false? Okay, everybody. And again, please get your votes in, otherwise you will not qualify for your CEU. Okay, so I am going to shut this out. It looks like everybody's been voting. Right, it looks like everybody said true.
Oh, look at that, 100%. You never get 100% of anything. That's awesome. Guys, that's it for today. That's a lot of information in a relatively short period of time. I hope I didn't overwhelm anybody. I know I overwhelmed myself, but I hope I didn't overwhelm you. And I just want to remind you that, you know, we have 5 other presentations that are very topical, I think, and very timely as part of the series that most of you, I think, are already aware of. And I'm going to stick around for a half an hour, or if not longer, to answer, well, not answer, to attempt to answer any questions you might have. So thank you so much for this opportunity again, and I really appreciate your participation. Thank you so much.
All right, everybody. Now, before I see people are starting to log off, and before you do, keep in mind that if you do not stay the remaining 25 minutes, then you will also not qualify for your CEU. It's important that you know that your CEUs are time-based and participation based. That's why we take so much time to analyze all of this data afterwards. So unless you don't need the CEU and don't have any questions, then you're free to leave. If you need that CE credit or CEU, then please stay for the duration of the Q&A part. Okay, so I'm going to start back in the beginning.
Okay.
So, do you recommend DBT for people with borderline personality disorder?
I'm not an expert in DPD, but here's the only question that no one's ever answered to my satisfaction. DBT for people with borderline personality disorder that do not have an intellectual or developmental disability, I think it's research-based. I think it's best practice. I think there's a lot of evidence of the efficacy of DBT. Here's my question, and I don't know the answer. How effective is DBT for people with a coexisting intellectual disability that also have a borderline personality disorder? I don't know the answer to that, and no one has ever really answered that to my satisfaction. So that's my feedback on that. I think DBT is a great treatment approach for people that are very resistant to traditional therapy, other traditional and more, historical therapies and counseling kind of paradigms. But people that have intellectual disabilities with borderline, I don't know how efficacious. I have a number of clinicians and peers that I work with, as you can imagine, that I respect, and they believe very strongly that DBT is absolutely appropriate and effective with people with borderline personality disorders. And again, we're talking about the higher functioning individuals, people that, you know, in the old days would be categorized as mild or borderline intellectually disabled. So that's the best answer I can give you on that.
Okay. Oh, and I could relate to this question, Karen. Is there a diagnosis for an adult that can go many days without sleep?
An insomniac. No, I don't know. I would like to know more. Are we talking about a pattern where they sleep normally and then they have a blip where they go a number of days with no sleep whatsoever? Because sleep deprivation can have its own significant behavioral and psychiatric issues associated with it. So I have heard of people that have this ability to go, you know, sleep is a biological necessity. At some point, you got to sleep. Um, so it's inevitable. You got to sleep sometime. But I would need to know more details about the individual involved and what the circumstances are. No, I don't think prolonged periods of sleep deprivation is good for anybody, and usually results in acute behavioral exacerbation. People are tired, they're cranky, they're on top of everything else that they already have going on. It's not healthy. But then you got to be careful because there are some people that I've worked with, for example, it's well known that people with autism, generally speaking, oftentimes require just relatively brief periods of sleep to be able to function. I got people at 3 or 4 hours a night, they're good to go. So if they're living in a group home setting and staff have them go, if they decide to go to bed at 8 o'clock, they're up at midnight. They're good for the day. And that's not necessarily a good thing either. So I would need to know more details, but prolonged sleep deprivation is never a good thing.
Okay. Yeah, I get just about 3 hours of sleep, if maybe two a night. So,
Oh,
wow.
that's impressive.
Ugh, not really. I'm tired. I need a nap.
Oh, you're talking about humorous, or that person just divulged that personal information?
Oh, no, no, no. I was making a side comment.
Oh, wow, that's impressive that you can function it on that amount of sleep. Okay.
Is, is it called functioning? Is that what I'm doing right now?
I guess that's debatable, right? You seem to be functioning okay, at least from a distance.
Woo, at least it's good. All right, so let's see. In regards to NOS, do you think that because the criteria was developed for neurotypical people, that the disorders might present differently with IDD,
Yeah,
therefore why they don't fit in with concrete criteria?
that's an excellent question, an excellent comment. And yes, I think that is why. Again, I referenced the late great Dr. Robert Savner, the thing that Dr. Savner was doing. And if you can look up some of his work from 20, 30 years ago, it's as relevant today as it was then, because I've never seen anyone duplicate one of the ambitions that Dr. Savner had. The guy was a freaking genius. Back then it was the DSM-3 or maybe even the DSM-4. He was establishing a criteria of mental illness specifically and exclusively to people with intellectual and developmental disabilities. Exactly what that individual just asked about. He was doing it. He was developing the diagnostic criteria as it manifested in people with intellectual disabilities, because as that individual is pointing out, the criteria that's utilized currently was in no way based upon um, individuals with intellectual disabilities. So yes, I'm not saying that anytime you see NOS, you should throw it out. I'm just saying raise your level of suspicion. And it might be that that is being ascribed for exactly the reason that person articulated. Very astute observation on their part.
Okay, so how do we get people diagnosed with borderline personality disorder? And also, sorry for two questions,
Yep.
are there big differences between oppositional defiance disorder in borderline personality.
Yeah, no, I don't. I think ODD and BPD, they got a lot in common. Um, the, the the other part of the question was, how do we get it diagnosed? Was that the
Yeah.
question? Yeah,
Yeah.
it's difficult because nobody wants to ascribe it. Don't take offense when I say this, but back in the day, I've been around long enough, and I've had enough friends who were psychiatrists that, tongue in cheek, we would call borderline personality disorder the psychiatric kiss of death. And I hope you're chuckling because that's supposed to be funny. And what it meant was, avoid it like the plague. Don't ascribe it. Don't acknowledge it, because we're going to be in trouble because we're not going to be sure what to do from a psychopharm perspective. Deb, you're not going to really know what the hell you can do from a behavioral perspective. They were right. Um, so you tended to avoid it at all costs. And I think that's one of the reasons why, even to this day, I believe there's a gross underdiagnosis of borderline for those reasons I just described. Nobody wants to acknowledge what it is because it means you got a heck of a journey ahead of you and a lot of work to do clinically. And even then, you might not end up with the results or the improvement from the individual that you're hoping for. Good question.
Okay, so any guess as to why we rarely see the depressive side of bipolar disorder?
That's a damn good question. I haven't really thought about that. I'm gonna start thinking about it now. I've only thought about the fact that I rarely, if ever, see it, but I haven't really taken my thought process to the next level as to why we don't see it. I don't know. That's a really good question, and I don't know the answer, but I'm going to give it some thought. Um, because I don't know why that is, but I'm hoping that the person, by asking that question, is validating my observation from their own personal experience, that they don't see that depressive phase in people with bipolar either. But and they're asking, why do I think that might be? I don't have an answer for that, but it's a very interesting thing to give some thought to.
Okay, so can you please share an example of a behavior plan for BPD? Hey, Julie, can you please be a little bit more specific on the BPD that you're talking about? There's bipolar disorder or borderline personality disorder. That was mentioned a few times that there's two BPDs. So please just put a little bit more information. We'll come back to your question. Okay, so I find it interesting that bipolar is oftentimes misdiagnosed. I too usually focus on the behavioral aspect and would have called it bipolar. I think that's just a comment. I don't know if you
Yeah,
have any.
that's a comment. I don't hear a question.
Okay, so resulting in the BPD NOS, bipolar. Okay, she didn't complete her question there, so I'm going to skip that.
Okay.
Hey guys, when you submit your content questions, please put as much detail as you can. As you can see, it gets flooded with the amount of attendees that come to many of these. And trying to piecemeal everything can be kind of a struggle and a challenge. So if you could put all of your information in that one comment that you submit to us, that would be perfectly amazing. um, Okay, so do you ever think that increased supervision with someone with borderline personality creates situations for more unhealthy relationships to develop and more behaviors to occur?
Absolutely. So if you're dealing with increased levels of supervision, which is very common in people with borderline personality disorder, is you got to keep usually a very close eye on them because you're not exactly sure what they're going to do or when they're going to do it. It has to be structured in such a way. This is where it gets really tricky. If you're going to provide one-to-one line of sight, arm's length supervision, which is not uncommon, then that person has to be very well trained in making sure that that person isn't getting a lot of secondary gain or reinforcement or attention out of having that person assigned to them for all the bad things that they do. Very, very tricky. Um, and remember, When you provide that level of supervision, and I already talked about people with borderline tending to form overly dependent relationships on particular staff, very common. Um, there's a propensity to do that with that assigned one-to-one. So that's an excellent question. And for all those reasons, you have to proceed with extreme caution the way that supervision and any interactions are structured so that that phenomenon that I just described doesn't occur, or you're defeating the purpose of why you're providing additional supervision and support in the first place. Because if the person becomes dependent on it, you'll never be able to break the cycle. That happens a lot, where the minute you try to back off because it hasn't been structured properly and the person isn't reinforced for allowing that person to back off a little bit in positive ways, they tend to want to do things that will warrant that person being with them possibly in perpetuity. So they have an assigned one-to-one. Then they start thinking of that person as their buddy because they have boundary issues and interpersonal issues. It can be a real problem. So, and I've had all of those pitfalls happen to me in my experience, trust me, on many occasions. I still haven't completely figured it out, but I think I'm a lot further along figuring it out now than I was a number of years ago. But that's an excellent concern and observation to have. These are good questions.
Alrighty. So what info could be provided when suspected an individual might have borderline personality, but has not been diagnosed?
Well, I'd go back to some of the criteria that I raised. Look at the family history. Is there any superficial cutting? Is there a desire to get to the emergency room? Uh, do they vacillate between being extremely pleasant and gregarious to being very rude and demeaning? Do you see that kind of extreme behavioral and personality presentation? Most of the people, when I wrote that stuff last night at the 11th hour, literally the 11 p.m., I was thinking about the people that I've worked with borderline. And, I guess I'm blessed in a way because the nature of my work over the years, to be quite honest with you, has been to become involved with folks that other people couldn't help. Um, and that oftentimes included me. I can't help everybody. I try. But so by default, I ended up dealing with a whole bunch of people with borderline personality disorder, either formally diagnosed or not, because they tend to be the more treatment resistive, treatment refractive individuals. But I go back and look at the criteria I mentioned. And, if you want other potential features, feel free to write to me and I'll give you some more. I just came up with the 6 or 7 that I see as fairly common. And you could take this information to a psychiatrist if you had this list and the person fit into these categories that I'm describing. You might be able to make a fairly compelling argument to that psychiatrist. He's going to be reluctant to go there. Most of them don't want to. They don't want to diagnose personality disorders. Nobody likes to do that. So there's a real disincentive.
Okay. So is this disorder diagnosed in individuals that are still in their teens or only as an adult?
Well, because I deal exclusively with so usually, at least it used to be that a person had to manifest some kind of a mental illness, including a personality disorder. I think I don't know, I'm not pretending to know, but I think it was late adolescence, early teens. Back in the day, many years ago, you had to have manifested a mental illness before the age of 18. Or I was like, really? You think about that now, how stupid that is. So does that mean you can't develop a mental illness in your 20s or 30s or 40s? Of course you can. But back in the day when the thinking was much more archaic, shall we say, the thinking was, there was age cutoffs. I don't think there's age cutoffs. I think people can develop a mental illness at any point throughout the lifespan. But since I only work with adults, it's hard for me to answer that question because everybody I work with for the last number of years has always been at least in their early 20s. I don't deal with adolescents or teenagers very, very rarely.
Okay. So do you feel like borderline personality disorder is overdiagnosed?
Not in my experience. That's why I'm saying I think it's grossly underdiagnosed.
Yeah,
No,
I had a feeling that you had already mentioned that earlier.
no, I think it's grossly. I can't. I've been doing this for 35 years, and I've dealt with probably 2 or 3,000 people conservatively, different people, and I can probably think of maybe 30 or 40 people that have been diagnosed with borderline personality disorder out of hundreds and thousands. That seems like an underdiagnosis to me.
Okay. So, what coping strategies are used preferably for people with borderline personality disorder? Does meditation or mindfulness techniques help?
Absolutely. There's a lot of promise for that stuff. Um, I'm trying to think. There is some kind of I think there's a computer program that I've heard about. I haven't personally used it, but many people have. I believe it's called Wild Divine. That sounds crazy, but if you Google it, you'll see what I'm talking about. Wild Divine. And I think it allows people to actually like put sensors on their fingertips and hooks up to laptops and does some like biofeedback, stress management stuff where they can start to self-regulate. And I've heard that that can be highly effective for some people. I've never personally used it. I know a number of clinicians that have that. It's been around for a while, so there might be different variations of it, but it was based on a biofeedback, self-calming, internal control mechanism kind of approach, which I kind of like. Kind of like Wild Divine.
Okay. So, how often, if at all, are ABA professionals consulted or involved in prescribing these medications?
Well, there's an individual tomorrow, I think, that's doing a webinar on exactly this topic. You might want to look her up. She's talking about on more ABA influence on categories in the DSM-5. I just know that, Marissa, from looking at your other webinar presenters. Uh, I was hoping to actually attend that myself, but I have some conflicts and I won't be able to. But generally speaking, uh, unless you have some knowledge of psychopharmacology, and I'm blessed, and I hope you agree that at least I have a little bit of knowledge in this area after today's webinar, most psychiatrists don't really want to take a lot of your feedback. Sadly, but true. Um, I think this will change over time. I think, the fact that there's a webinar tomorrow on exactly this topic is evidence of that. But, I tend to get psychiatrists to, I can be very, very influential, let me put it that way, on how they prescribe medications because I can articulate reasonably articulately um, what what my thoughts are and what my knowledge is and what I think might work and what might not work based on my previous experiences and what I think might be going on. And if you get a competent, confident, those are the key words, psychiatrist, they love that kind of feedback because they don't get a lot of that. But then I'll get other psychiatrists that, very pompous, arrogant. Well, Kev, where did you get your medical degree? I've had several people ask me that. And I go, I don't have one. Why? Well, what makes you think you know about psychopharmacology? Well, because I do, because I've studied it. Why? But just because I'm not a doctor doesn't mean I can't know something about the topic that you're an alleged expert in. Well, I don't say that because that's being abrasive, but you get my point. Um, I think if you go in there and you have some knowledge of psychopharm, um, that's probably more advantageous in influencing not only diagnosis but potential medications that are prescribed than anything else at this point.
Okay. So, how do you develop a relationship without giving personal information? I've had complaints from parents that staff are too cold or not personable enough.
It's a good question. Um, I usually have staff, I usually have a script for the staff that work with people with borderline personality disorders. Um, and they may say things like, I really enjoy working with you, but I'm a staff person that's here to support you. I don't share information about my personal life with anyone. So I have this kind of scripted response that hopefully everybody uses. Um, that may be perceived as cold. I don't think that's cold. I think you can tell people that you like them, that you care for them, that you enjoy working with them without necessarily divulging where you're going to go on vacation next week and how long you're going to be there and how much you paid for the hotel. I don't think that's anybody's business. And unfortunately, when you divulge that kind of personal information to a person with a personality disorder, they're going to take liberties with that. And that can create all kinds of problems. So I'm sorry that people feel that that might be a cold approach, but diagnostically, clinically, it's the right approach to take from a treatment perspective. It's good question, good observation.
Okay. So I am a BMS, and one of the biggest issues I run into when dealing with staff in my residential arrangements is not taking the behavior personally. Not taking something personal is very difficult to teach.
Oh, is it ever? That's
Uh,
why I talked about the titanium plate. You can't get through my armor. This is impenetrable. And so when I train staff that are going to work with people with borderline personality disorder, now I can't I can't make them develop a titanium plate. That's a personal thing. And I'm obviously using that term figuratively, not literally. But I can let them know that most people with personality disorders will try to personally attack you to break you down psychologically, emotionally. And if you let them do that, shame on you. So I kind of look at it as preparing troops to go off to war, tongue in cheek. So I sit down and this is what you have to be prepared for. Put up that titanium plate. Don't share personal information. Don't ever cry. I've had staff start crying when a person starts that they support. I hope your baby dies, and nasty, terrible things that are said. And then the person literally breaks down, and I go, oh, no, no, no. You can't be doing that because you let that person penetrate you. And now that they've seen that they can do that to you, they look at you as someone that they can easily manipulate and control. And that's the opposite of feeling that we want them to have. So I can totally respect what that person is saying. It is not an easy thing to do, but it must be done, or you're already compromising the interventions when you allow a person in. Can't do it.
all right. So how do you feel about CBD products or medicinal marijuana?
I have very little experience with it. I don't really have an opinion on that because I have such little. Uh, I don't believe in the states where I routinely work, and I might be wrong. I don't think in Connecticut or Massachusetts, where I do the majority of my work, although I'm elsewhere. I'm not even sure that medical marijuana is an option for people with intellectual disabilities. I don't think the bureaucrats have come to the conclusion or realization, or from a regulatory perspective, that that's something they're necessarily going to allow. And I'm honestly not familiar with CBD. It's all the rage. The commercials are all everywhere. Rub it on your body, drink it, smoke it, rub it on your hair. Apparently, it does everything. Um, so I'm saying that with a sense of humor. I hope you get that. But I know very little about CBD. I honestly do.
Okay. It is 2:30. I don't know if you wanted to take more questions.
If there are more, I'll stick around.
There are like so many more. We'll be here for hours at this point.
Like I said before, as long as someone orders pizza.
Okay, well, let's see, guys. I'm gonna just pick through some of these so we can kind of get wrapping up. I know a lot of if you guys did stay until this point and needed your CEUs, then you do qualify and you are able to go if you have like another oh, everybody's logging off already. Okay, so it jumped down like 10 people in that 1 second. All right, everybody. So you do qualify for your CEUs. I will be getting through all of the data and everything by Monday. So do not ask me tomorrow or today for your CEU certificate. You will get that on Monday, and probably around lunchtime. I will have that done. But we do have quite another webinar tomorrow. I just won't have time to analyze all the data and do the webinar. So,
And just one other thing I want to say, because I know we probably won't get to all the questions, but
mhm.
people feel free. If I can't get to a question, you see my website, you can contact me directly through my website. Send me your question personally. I'll be more than happy to respond. It's not a problem.
Okay. All right, everybody. So, let's see here. We'll get through a few. All right. So everybody's asking about the PowerPoint. As I said, you can download the PowerPoint through the handouts section of the control panel, or send me an email and I will send it to you tomorrow when I check my email. What are your recommendations for tools or assessments to be used to assist direct care staff during psychiatric appointments in addition to behavioral data?
I believe I have a template that if that person contacts me directly, I believe I have a template that I developed at one agency. I'll have to slightly modify it so I don't get in trouble for using an agency's form. But since I developed it, I don't feel like I can't use it. I just have to take their name off of it. And if that person contacts me with an email address, I'll be happy to slightly redact it and send them a copy of it. Just some basic one-page form. It's not perfect, but it's better than going in there with nothing, right? Because then you're fresh meat. So a big part of the problem of getting good psychiatric care is the lack of preparedness of the staff. Not to mention, most of the last year has been telehealth anyway, which I personally can't stand. I like to meet people in person for lots of reasons. So the telehealth is compromised, the procedures. Some people are actually doing phone consultations. I don't know how you do that. You can't even see the person. So I do have a template that's simple, but that asks some questions that when filled out, I think much better prepares staff when they go to a psych appointment with an individual. They give the individual, the practitioner, this form. I think it's a good supplement to anything else that might take during that consultation. Be happy to send it to you if you send me an email. I just got to retrieve it, take the name of the agency off of it, so I can send it to you in confidence.
Okay. So earlier you mentioned having those boundaries with clients. What are some good strategies to teach boundaries to staff members who take one of the mom roles or just struggle to maintain boundaries?
Read the question again, please, Marissa.
Earlier, you mentioned having those boundaries with clients. What are some good strategies to teach boundaries to staff members who take, I think they meant take on the mom role or just struggle to maintain boundaries? So
Yeah,
it's like they're trying to act like mom.
yeah. So that I talk about this a lot. I call it the parent-child paradigm. If this makes sense to that person, and I think it will. When you start treating individuals like you're the parent and they're the child, or they're the mother, or they're the father, and they're dealing with kids, you're usually going down a very slippery slope. There's a difference between structure and limits and boundaries. And treating people like you're the ultimate authority, or what you say goes, or you have all the power, because then you can get resentment, you can get a lot of friction, you can get a lot of combativeness. And if you're not careful, those scenarios can oftentimes lead possibly to an abusive or neglectful situation. So boundaries is key. Again, this goes back to training. Um, Firmness in imposing rules and in helping the person understand what the rules are is different than treating a person like they're your child, or I'm your mother and you will do what I tell you to do because I'm your mom. Um, there's little nuances in all of this stuff that make a big difference. So that's a tough question to answer, but I know exactly what she's talking about when she uses the word mom. I got a lot of staff that treat individuals that I work with as though they're the mom, or if they're a male, the dad. And I'm constantly cautioning them of what their role is and what it isn't, and what they can and can't do.
Okay. So Let's see here. Do you have any thoughts on how long an individual should be on any one medication before taking a break or working to reduce the medication? What factors may lead you to decide it's a good time to reduce?
So if a person, there's no pat answer for that because it varies by individual. As a general rule, my belief is that if a person has been on a medication without any alteration, titrating up or down, just stable plateau, for ballpark 5 years, 3 to 5 years, and they appear to be clinically stable, behaviorally stable, psychiatrically stable, their mental health is good, um, then it might be time to consider making an attempt to titrate the med to see if the person. See, the one thing you have to understand about mental illness and mental health, and I think a lot of people forget about this, an intellectual or a developmental disability, right? That's a stagnant entity. Let's just be honest. That doesn't, the, the cognitive or neurological damage that the person unfortunately has suffered doesn't really vary. It is what it is. Now, learning can take place, skills can be developed, of course, but that baseline level is pretty much what it is. The difference between that and mental health or mental illness is mental health and mental illness it fluctuates, it waxes and wanes. Um, how many people have we heard about that were non-disabled that had an acute psychiatric episode, maybe went explosive, maybe went crazy, you killed people, whatever. And then we find out in retrospect that they stopped taking their meds. Right? You hear about that a lot because they didn't think they needed them anymore. So let's not make that mistake. But I do believe if a person, and again, there's no, I'm giving you Kevin's rule for what that's worth. 5 years of stability across the board with no evidence that the person, now, remember this, the fact that they've been that incredibly stable for that long a period of time could mean precisely that they're on the exact proper medication at the exact optimal dose. So it could mean that as well, but you don't know until you. So I believe that after about 5 years, if I've seen no fluctuation in the individual's presentation and the medication has been absolutely stable without any titrations, at that point, I will usually go in, particularly if it's an antipsychotic med, right? Because you always want to get them down to the lowest possible dosages. I may say to the psychiatrist, "Hey doc, do you think we can try to titrate the med and see how they're going to respond, and see if they can tolerate a reduction, and maybe with the goal of maybe eventually discontinuing, which might be overly ambitious, but again, you don't know till you try." I believe people that we support are entitled to the opportunity to demonstrate to us that they can maintain stability in the absence of being on medication. I believe that, with rare exception. Um, so that's a long-winded answer to a good question.
All right. Can you spell the name of the psychiatrist you were referencing?
Yes, Dr. Robert Sovner. His last name is S-O-V, as in Victor, N-E-R.
Okay.
Dr. Robert Sovner.
All right. Sorry, so many questions regarding his name, and I'm just clearing them out.
Good.
Okay. So, do you have any recommendations for the best way to approach the prescribing psychiatrist about increasing the frequency of blood draws or decreasing the rate of titrating a psychotropic medication without insulting their expertise?
Yeah, we have to be careful because the egos out there can be pretty big and pretty bold. Um, Usually I can get psychiatrists to do blood draws on the Kevin schedule, which is Q3 months. When I explain to them that I've had people, yeah, I'm not a scare tactic, but I'll say that I've had people that have died, which they have because they didn't do blood draws as frequently as maybe they should have, or people we couldn't determine if they were toxic because we didn't have the indicators like speech or disturbed gait. So that it's just prudent to do things more regularly than that. And very rarely will they fight me on that because, once they start to think of it, this may seem devious, but I can be devious. Once they start to think of it as like a liability issue, it's like, I better listen to what this guy says. If he says every 3 months, maybe I should do that. So I can usually get them to go along with that without offending them. The other part of the question had more to do with the approach. I always try to couch things when I'm interacting with psychiatrists, which I do frequently. I throw out ideas. I mean, my typical interaction is something like this. Hey, doc, I was thinking that Joe's been on Risperdal now for like 5 years, right? And he's on 6 milligrams, and that's the maximum dose. And he's doing real well. But do you think after all this time, maybe we could reduce it just a little bit and see how he does? Does that seem reasonable? So you don't have to write that down, but tell me that's a very effective approach because I'm being very respectful. I'm giving them some reasonable thought as to why I'm suggesting what I'm suggesting. And then I'm deferring to their expertise to make the determination as to whether or not that's something they might want to consider doing. If you approach a psychiatrist just like I did, my success rate, I've oftentimes said, and I'm joking when I say this, that I practice medicine through them. I can get them to do things, it's scary. But, as long as it's well thought out and it makes sense and they're on board with it, why not? So the approach is critical. If you turn off a psychiatrist, I've done it. I've gone in there when I was younger, a little bit more pompous, a little more arrogant, a little more ego. They'd shut me down. And it was like they didn't even want me to come to the appointments because I came across like a jerk. So as I've grown older and hopefully wiser, I've tempered my approach because at the end of the day, all I want is for that person to make adjustments that hopefully ultimately are going to be beneficial for the person that I'm there to support. So that little dialogue I gave you, I hope is helpful. I think if you use it, it will be.
Okay, so let's see. Let's try to wrap the last few questions up. Okay, everybody. So if your question was not answered today, then as Kevin said, feel free to go onto his website to submit the questions and email
Yep.
him. Just he said it a few times earlier. I'm just pointing it out again because I see some people asking how to submit questions directly to Kevin. That's
Yep.
exactly how to do it. He mentioned it earlier. Okay, so that's an opinion. Okay.
A good opinion or a bad opinion? A dissenting opinion?
Is it
Don't
too
read
late
it out loud if it is.
CEUs? Ryan, no, it's not too late to purchase CEUs. As I said earlier, it'll be available throughout the weekend, and you can decide, Sunday night if you wanted to purchase CEUs or Monday morning. But I will have everybody's CEU certificate stuff in your inbox by Monday lunchtime. As I said, I have another webinar tomorrow, and I just won't have time to do both, because it takes a while to make sure that such a large audience actually participated and stayed the entire time they should have stayed to qualify. All right, so I am going to end it on this last question. So are there any vitamins and supplements that are clinically proven to improve overall well-being?
I'd have to go to my kitchen counter and look at the bottles of stuff that I've been taking for 20 years to see what the ingredients are. But the answer to that question is specifically, I don't know what the names of those herbs or supplements are, but I can tell you that I'm a great believer in naturopathic, holistic, healthy supplements. I think one of the biggest problems in the field that we have with the population of people that we support is that people don't try natural alternatives. There are herbs and medications, organic, that are grown, naturopathic supplements that I believe will elevate a mood state, and do elevate mood states. I take some of them. I can't tell you how effective they are because I've been taking them so damn long. I don't know what would happen if I stopped taking, but I think they work for me. Um, I would recommend that you do some research, Google it. This is an area that that's untapped. Uh, a lot of states don't. They make it very difficult. Let me put it that way, to put people on some of the supplements that you and I can get at any health food store. They make it very difficult for us to be able to utilize those same agents for people we support. I think that's very unfortunate because I think there are people that I've worked with that probably would benefit from. There's certain herbs and supplements that affect that have anti-anxiety properties, antidepressant properties, no question about it. And I think the fact that that's like an untapped area with this particular population is really unfortunate. So I think that's a good question and a good observation.
Okay, everybody. So we are going to end up wrapping it up there today. So if your question was not answered today, please go on to Kevin's website and submit if you still have any further questions or anything. As I said, I will analyze your CE certificate, your CEU qualifications and everything like that, and have your instructions to you on Monday. So please, I appreciate your patience with that. Um, there's still obviously plenty of time. There's 5 other sessions for the rest of this series. And the last session I believe is in August. So please feel free. Purchasing will be up and available for CEUs, or you can just go and register for the free event. But you might as well just get your CEU if you could too, I guess. But those are still available in the store as well. So with all of that, I think that's about it for today. So again, I appreciate your patience, and CEUs will be coming on Monday before I get like so many emails that I can't even answer asking when the CEU certificate will come out. You will get an email in like probably 15 minutes with a certificate of participation. No, that is not your CE certificate. So do not be worried that there's no BA, your certificate number is not on there or anything like that. It's just for everybody who freely attended, basically, who's not certified. Okay, everybody, that's all I have for today. Kevin, thank you so much for doing
Thank
this.
you, Marissa. Thank you, everybody that participated.
All right, everybody, enjoy the rest of your week. And if you're coming to the DSM-5 webinar tomorrow, then I will see you then. And if not, then maybe go register and definitely probably come. Monica's an amazing presenter as well, just like Kevin. And I will see you guys probably tomorrow. If not, I'll talk to you on Monday for your C's. Bye, everyone.
Bye-bye.